Babies also do not have the ability, if they develop hypovolemia, to draw blood into the central circulation. They have immature baroreceptor activity. And when we're dealing with these babies in the OR, especially in the immediate neonatal period, up to 2 months of age, they're at increased risk for what we call reversal of flow or going back into fetal circulation. If that does occur in the OR, they can have significant problems with hypoxemia and or potential for cardiac failure. In terms of respiratory function, they have increased minute ventilation as compared to adults. Thus, we need to meet their metabolic demands in terms of increased respiratory rate on the ventilator. Normal respiratory rate in an adult is anywhere from 12 to 15 breaths per minute. In a neonate, it can be anywhere from 30 up to 40 breaths per minute. They have markedly increased oxygen consumption. As I'd mentioned to you before, babies grow. They need a lot of calories for growth. To grow for that energy, you need oxygen. The normal adult consumes anywhere from 1 to 2 cc's per kilo per minute of oxygen for normal function. A baby can consume anywhere from 3 to 6 mLs of oxygen per kilo per minute for normal function. And again, the babies, as we have seen in the NICU, are more prone to apnea, probably related to a number of factors, one involving the respiratory system. In terms of neurologic function, babies have a greater amount of cardiac output that goes to the brain. In the normal adult, the cardiac output is anywhere from 10 to 15% of cardiac output goes to the brain. In babies, it can be anywhere from 20 up to 30% of cardiac output goes specifically to the brain. Neonates also have immature blood-brain barriers. For that reason, when we provide narcotics, specifically fentanyl, which is very lipophilic, which binds, lipophilic meaning binding to fat, there's a greater proportion of fentanyl that will go to the brain since there's a lot of lipid in the brain as compared to the adult. Again, as I mentioned to you before, babies are prone to apnea, and because of decreased or immature neurologic function, this also contributes to the problems that they have with apnea. In terms of renal function, babies have decreased glomerular filtration rate. They have decreased tubular function. They do not, as you can see in this slide, reach adult levels in terms of renal function until probably 8 to 12 months of age. For that reason, babies have an inability to concentrate their urine. They have an inability to get rid of excess water. So it's very easy to overhydrate them. It's also very easy to have significant electrolyte abnormalities associated with the baby due to decreased renal function. In terms of hematologic values or function that we encounter every day in the OR with neonates, they have increased hemoglobin and hematocrit. That's important because in utero, they have to have more red cells to carry oxygen because they live in a basically an anaerobic environment. Shortly after birth, hemoglobin can be anywhere from 15 grams per deciliter, and hematocrits can be anywhere from 45 up to 55%. This will decrease with age and will drop to what we call the physiologic nadir at 2 months of age. There's a relatively greater blood volume in babies, and that's also dependent on their level of maturity. The more immature the baby is when they're born, the greater relative blood volume. In the normal adult male, there's approximately 70 cc's per kilo of blood within the body. In the neonate, the extreme premature, under 30 weeks gestation, you can have anywhere from 100 cc's per kilo. Remember though, if you're only 1 kilo, that's only 100 cc's of blood. Where in a normal adult, it can be anywhere from 5 to 7 liters of blood. There's increased fetal hemoglobin, which can change the oxygen association curve, and they have greater propensity to carry oxygen and difficulty in terms of disassociating the oxygen. There are coagulation factors. The neonatal serum coagulation factors are decreased due to decreased hepatic function. So all neonates have increased PT-PTTs and are prone for greater issues with bleeding in the OR. Now, to speak specifically about pharmacologic considerations that we deal with in the OR every day, babies have increased volumes of distribution. What is volume of distribution? Volume of distribution is the amount of water contained within the body in which drugs are dispersed. Why do babies have a greater volume of distribution? The reason for that is they have increased extracellular fluid. In babies, they can be up to 40% extracellular fluid, where adults is more 25 to 30%. They also have decreased hepatic and renal metabolism. Almost all drugs are metabolized either by the liver or the kidneys. Again, decreased function in both of those. So when a drug is administered to a baby, it can last longer in terms of its effect. In terms of, as I mentioned to you before, going back to increased volume of distribution, a drug, if we administer it to a baby, since there's that greater volume in terms of the drug being dispersed, there will be a less or lower peak level of drug as compared to adults. Neonates have decreased serum proteins, and this is related to a number of factors, specifically the hepatic function. The liver produces a number of proteins which are involved in binding drugs. One of those specific proteins is alpha-1 acid-glycoprotein. It is the specific protein to which bupivacaine, or one of the local anesthetics we use in the OR, is bound. So with that in mind, if you give a dose of bupivacaine to a baby, they can have a relatively higher free level of drug as opposed to the adult, since they have decreased levels of alpha-1 acid-glycoprotein. I'm now going to speak specifically about intraoperative anesthetic management of the neonate. And in doing so, I'm going to go over a little bit of history involved with anesthesia for the newborn and neonate. This has actually evolved fairly dramatically in the last 30 to 40 years. Anesthesia for neonates, in the past, we used to use what was called a Liverpool technique, and it originated from Liverpool, England. And basically, the babies would be intubated, paralyzed, given nitrous oxide, and hyperventilated. They were not given any of the anesthetic agents that are utilized now in terms of taking care of neonate in the operating room. If you look at this, is the only way we could provide anesthetic for neonates, because everyone was concerned that if we did give them an inhalation anesthetic, such as ether or halothane, that there would be significant problems in terms of managing the babies and the potential for death. There was significant morbidity and mortality associated with doing surgery on children or neonates when we used the Liverpool technique. In 1981, Drs. Robinson and Gregory demonstrated that fentanyl, an IV narcotic agent, could be given safely to neonates for PD ligation. Significant amounts of fentanyl were given at that time, up to 50 mics per kilo, and as I'd mentioned before, the neonatal brain is different from the adult brain, and if you give that large amount of fentanyl to a baby, they would be asleep for several days. Dr. Anand demonstrated in the 80s that there was significant stress response in the OR due to surgery, and that in giving fentanyl to babies, the stress response can be ameliorated and there are less issues with morbidity and mortality postoperatively. Dr. Yasser in 1987 demonstrated a dose response for fentanyl for neonates, which was approximately 12 to 15 mics per kilo for most neonatal surgeries, i.e. mostly intra-abdominal procedures. The babies would have an adequate anesthetic and would waken from the anesthetic in a reasonable amount of time. Dr. Lerman showed in his studies that MAC, or the minimum alveolar concentration, or the unit of measure we use in the OR for determining the potency of inhalation agents, is highest at 6 months of age. There's two peaks that occur with MAC, 6 months of age and an adolescent period. The premature baby, the more premature you are, the lower your MAC is, or minimum alveolar concentration. The older you are, conversely, in terms of the elderly octogenarian, the lower your MAC is also. So there are extremes of MAC at both ends of life. In terms of the modern anesthesia for neonates, in terms of the agents that we use, we now are incorporating the use of inhalation anesthetics. As I mentioned to you before, the number of studies looked at fentanyl, an IV narcotic agent, as a safe anesthetic to provide for neonates. In the past 30 to 40 years, we've gotten a better understanding of the effects of inhalational anesthetics on neonates, and we now can safely administer inhalation agents such as isoflurane, sevoflurane, desflurane, and maintain normal blood pressure, respiratory rate, or function in the OR for the neonate. We continue to use fentanyl as our primary narcotic in the OR for pain control or as a supplement to the general anesthetic, and we also are utilizing morphine more readily in the neonate. We've had a better understanding of pain mechanisms and pain control for neonates. We also utilize neuromuscular blocking agents. As I mentioned to you before, we use Pavilon as our primary agent, a very effective agent for neonates, specifically because it's a vagolytic agent and it causes the heart rate to rise. But we also now use vecuronium, rocuronium, and cisatracurium. Rocuronium, cisatracurium are very effective agents, and they don't have the prolonged half-life as one would see with pancuronium. And one of the more exciting aspects of neonatal anesthesia that we use now is the incorporation of regional anesthetics within the OR and outside of the OR postoperatively for pain management.